Uh, so, I, you know, how do we get a handle on this gene that is mutated in 1 in 4 human cancers? G protein mutant RAS is all over the place, and this metaphor being, it's very comforting to classify a lung cancer with a driver oncogene, and you feel like you've got a handle on something, but there's so many different types of handles, right? The different isoforms of RAS and HRAS and melanoma. I'm sorry, HRAS and skin cancers, NRAS and melanoma, and then the KRAS families, the isoform 4B being the predominant form that's mutant in lung and colon and pancreas cancer. And then it's a promiscuous G protein, so there's so many different downstream signaling pathways with this oncogene that you really don't know if you've got your handle on this mutation, but are you holding a broom or a shovel or a rake? What's the cell doing? What's the cancer cell activity that you've got in hand? And so just knowing that you have a RAS mutation, I think, is important to get a foothold or a toehold in classification, but then understanding the biology is going to be lineage and organ specific. And then in addition to knowing about the mutation, there are transcriptional and translational and amplification issues. So the complexity is great, but it's still nice to have a handle on a disease subtype. And that's the utility. The second level of complexity is there's more than one type of KRAS isoform 3B mutation. And this is a pie chart from Memorial Sloan Kettering, which did exon 2 sequencing in KRAS on a large cohort of patients. And you see that the majority of KRAS mutations in lung cancer are G12C, and then other amino acid switches in the position 12 and 13. And I don't think they tested exon 4 or the Q61 in this assay. So why should we test for KRAS? It's kind of like my talk this morning. Why should we genotype early stage lung cancer? I think because you want to make the diagnosis, and I think this is a unique subtype that has prognostic implications. So the Memorial Group also looked retrospectively at the 1,000 patients they genotyped and showed that the KRAS mutant, which is this green line, had a slightly worse survival with advanced lung cancer than EGFR, which is this red line, or the EGFR KRAS wild type, which is this blue line, with a hazard ratio in comparing of about 1.3 or so. So I think it matters prognostically that you have KRAS. It tends to be bad, but we also know we have all managed patients with KRAS mutations who have incredibly bland natural history. So that's not the whole answer, but a general sense that there's prognostic implications here. But the real reason we check for KRAS now is because there's a sense that it's mutually exclusive to important driver oncogenes, EGFR, ALK, ROS1, and then add on BRAF, V600E, MET, so that it's very satisfying as long as we're classifying the disease in terms of driver oncogenes to use to check for KRAS mutations in a classification and taxonomy sense. So I think no one would question genotyping advanced lung cancer for KRAS. And a lot of that has to do because we're already, the KRAS mutation is found very often in the platforms used to find, say, EGFR mutation. And this is the data from early stage patients, resected patients with KRAS mutation versus wild type, where there was no prognostic significance to finding the KRAS in an early stage resected lung cancer, but still taxonomy matters. So what are the approaches to drugging KRAS? You can go for the you can go with direct inhibition of the GTPase. You can inhibit its association with the inner plasma membrane, which is necessary for RAS action. You can target downstream effectors. And you can even get very specific and do synthetic lethal screens to see which partners can be downregulated and then kill the cancer because the cancer is over-reliant on the downstream partner. There's a sense that KRAS-driven cancers are very dependent on targetable metabolic pathways, so a lot of interest in anti-metabolism drugs targeting like aerobic glycolysis or the anabolic processes that the cell needs to continue to listen to that KRAS signal. And then lastly, there's a sense that perhaps there's unique antigenicity here for KRAS or unique mechanisms of immune evasion that may be specific to this genetic lesion. And so, but the trouble with drugging KRAS, at least with direct inhibitors, is that this is the active RAS GTPase bound to GTP and active binding to downstream effectors. This phenomenon, binding of GTP to RAS, occurs with picomolar affinity. It just happens automatically inside the cell, and so and GTP is in millimolar concentration inside the cell. So it's not like using ATP mimetics to target other tyrosine kinases. It's hard to design a molecule that's going to get in there and outcompete GTP. And the mutant RAS, which has mutations at exon 2 codons 12 or 13, or exon 4 Q61, basically has an impaired GTP hydrolysis. So this unit is stuck in the on position, as it were. So, and then the news, which is preclinical news, there's no data on this this technology even in animals, but minimal in animals. But basically, they've discovered direct covalent compounds that bind directly to mutant KRAS, and so they went after the most common form, G12C, and using screening cysteine-reactive small molecules, they were able to find, this is a group of investigators at UCSF, was able to find a compound that bound to the position 12 cysteine and kicked out basically the GTP, and it was a covalent binding, so that it didn't have to worry about the affinity of the GTP for that pocket. So these drugs have been discovered, but they're not optimized for clinical use. Another group used a GDP analog, SML 8731, that also bound covalently in that pocket. It's a highly negatively charged molecule that they can't get into cells. So they're struggling with bringing these drugs into clinical use, but the optimization is in process, and it looks very exciting, at least for G12C targeting, and that would be in lung, colon, and pancreas cancer. So what we're seeing in the clinic is you pick your drug to combine, and single or dual pathway inhibition of downstream effectors, whether or not you have data of synthetic lethality. And that's why there's very little data in this talk, because there's just an enormous amount of phase 1 and drug development data using inhibitors of the downstream effectors, PI3 kinase, AKT, mTOR, RAF, MEK, and ERK. And so maybe folks who have their favorite drug will come to the podium after I'm done and tell us about it. What you end up with is a lot of great ideas once you've got a mutant RAS to target in combination. So here's just my short list. Some of these things that I'm familiar with from practice in Boston, for example, combining the MEK inhibitor trametinib with TBK1 inhibitor, momelotinib, based on synthetic lethal work by David Barbie, or the MEK inhibitor trametinib with a BCL-XL inhibitor, navitoclax, based on a synthetic lethal work by Ryan Corcoran. And these are really neat designs for KRAS mutant lung cancer. But there's so many of them, and there's a lot of phase 1 data, and I'm not sure which of these is going to come out on top. But you see, the common theme is you tend to combine a MEK inhibitor with some other approach, including chemotherapy. And I'll close with the compound closest to clinical use, which is the MEK inhibitor selumetinib. And the way I understand this is KRAS-driven cancers have overactive BCL-XL based on the cell action. And then if you block the KRAS path with a MEK inhibitor, you downregulate BCL-XL, and then the docetaxel works better. And so in a randomized phase 2 study, you see the addition of selumetinib to second-line docetaxel improved both PFS, and that the trend for OS was favorable. And so it's a good phase 3 concept, and the SELECT-1 trial just completed accrual, so we'll see whether this pans out in phase 3. It is, if you put people on this combination, it's toxic mostly because of the 75 per meter squared of docetaxel. But indeed, when you add the MEK inhibitor to docetaxel, you increase rates of diarrhea, nausea, vomiting, peripheral edema. You get this macular rash, mouth sores, and I've seen a couple of patients with the retinopathy and visual changes. So it is toxic, but it may be effective. So, and there's another phase 3 study out there using a CDK4/6 inhibitor, abemaciclib, taking on erlotinib head-to-head in previously treated KRAS mutant patients. A bit of a paper tiger taking on erlotinib in a KRAS mutant population. And I'm not sure what's happening with trametinib, but I think Dr. Blumenshine or others might comment. So, and what about immunotherapies targeting KRAS? Well, the Matt Hellman's subgroup analysis at World Lung in the KRAS mutant population of the folks given pembrolizumab, 87 patients with KRAS mutations versus 238 wild type, and didn't see an efficacy signal in KRAS mutant specifically, but a lot of ideas of how you can use a KRAS specific antigen antigen signal to use immunotherapies here. We did a study at Memorial using a yeast-based vector to inject mutant RAS oncoprotein under the skin to see if we could stimulate immune responses. So in summary, checking for KRAS mutation and doing the genetic test in advanced disease has diagnostic and prognostic utility. It tends to exclude the driver oncogenes which are druggable, which helps with taxonomy. I think that when you look across the field of RAS targeting, I think that we're going to have to get disease, organ, and lineage specific, isoform specific, and even mutation specific. And that is a nice segue to the fact that there are now direct inhibitors of KRAS G12C that covalently bind and block the enzyme. Combination studies of downstream effectors and synthetic lethal partners are all over the place and abound, and there's no direct link to immunotherapy yet. And then the phase 3 studies are underway, including DOSI with selumetinib and abemaciclib. Thank you very much.
So if a patient walks into your clinic Monday, what is your go-to thing for KRAS? Is there one that you have?
Yeah, there is no drug for KRAS. So,
but of all the things that you showed, is there one that you have a particular?
Yeah, it's from a practical approach, I think that if you have KRAS mutation, you tend to have adenocarcinoma, and you're more confident that it's adenocarcinoma if the histology is suspect. So it's again, it's a biomarker that none of us mind checking, but it really doesn't have practical relevance yet.
Any other questions?
What's happening with trametinib?
Oh, so my turn, okay. So, as you know, the single agent data versus docetaxel is essentially equivalent, but there were higher rates of toxicity in the trametinib arm. So that didn't go forward. And then the studies looking at combinations with docetaxel and or doublet chemotherapy ran into some of the same issues that you mentioned with selumetinib and docetaxel in terms of higher levels of toxicity. At the end of the day, I don't think that's going forward in that space. Now, it's still moving forward in melanoma, obviously, and I think there are plans to take it forward in combination with some of the checkpoint inhibitors and see how that works out in looking at KRAS specifically.
KRAS specific. Okay, thank you.
All right, thanks very much.